All right, welcome everybody. Thank you for joining us. I am Ashley Meyer. I'm stepping in today for Najla Nasri to moderate today's journal club. I am a cognitive psychologist from Baylor College of Medicine and the Houston VA, and also co-chair of SIDM's research committee. For today's journal club, we thought we'd have an encore presentation of what the SIDM fellows presented in a concurrent session at DEM about a month ago. It was really well received, and they were lucky for us, willing to represent it. So we're fortunate to have Kelly Gleason, Alexa Miller, Vanita Parkash, and Caitlin Clancy, all 2018 SIDM fellows, join us to discuss their work and some favorite diagnosis articles they encountered this year. I think it will be a great session, so thank you all for joining us. All right, so now on to today's presentations and the reason why you're all here. I'm pleased to introduce the first speaker. It is Caitlin Clancy. She is a pulmonary and critical care fellow at the Perelman School of Medicine at the University of Pennsylvania. And she's going to talk about diagnostic accuracy, harnessing the power of the group.
Thank you so much. I'm very excited to present to you guys today. So glad to be invited back to do this encore. Is everyone seeing my slides okay? I'm gonna make them
no.
No? Okay, I think it should be going now.
Yep.
You can see? Okay, good. Thank you.
Yeah, thank you.
Okay, so I'll just start by briefly telling you guys about what I'm interested in doing and what I've been doing through my work through SIDM and how then it relates to a really interesting paper that came out earlier this year. So my focus has been really on trying to understand the conversations that happen in the clinical environment surrounding clinical reasoning through real patient cases. And I've done that through in a couple different settings. I've looked at subspecialty precepting of outpatient visits and done the conversation maps to look at how in a dyad between a subspecialty fellow in internal medicine and a preceptor in that subspecialty, how they discuss patients and how they kind of go back and forth through a case presentation and end up talking then about ultimately leading to talking about the assessment and the plan. And then I'm currently still collecting data on a study where I'm doing the same sort of idea of doing conversation mapping, but instead of the outpatient setting, doing it in the inpatient setting, talking about new patient admissions as they come in. And the idea here is that potentially using some quality improvement methods to understand process that we can try to find ways to target a reduction of diagnostic error through coming up with standardized ways to talk about patients. But this is all sort of a explanatory process at this point to figure out, well, what are people actually saying and how are these conversations taking place? And then pretty closely related to this is another project that is out for publication, right, or out for review now, where I looked at with a group of collaborators from a couple other places around Philadelphia, looked at resident decision making working in peer groups, with the idea here being that when residents work together and sort of check their clinical decisions with their peers. In this study, we looked at value, but could certainly I think most of us can see the connection pretty easily between value and diagnostic error. And in particularly, we looked at uncertainty, and the sort of spoiler of the results is that when residents work together in groups through patient case vignettes, they felt more certain in their answers about what to do, what to order, what to do next for the patient, and using sort of a validated measure of value in their decision making made higher value decisions. And so that's sort of the landscape in which I was approaching the literature and trying to pick out what I wanted to share. And so I'll get right to it. So the paper I chose was a paper from JAMA Network Open, done by a group who looked at comparative accuracy of diagnosis by collective intelligence of multiple physicians versus individual physicians. And I'm going to get into sort of the details of how they set that up. Many of you guys know that this study is actually using data from the HumanDX project, humandx.org. And for those that aren't familiar, this is an interactive website where people post cases, and you can work through to get to answers. It's meant to sort of build clinical reasoning skills. What they ended up looking at was, for the study, was about 1,500 cases with 2,000 unique users. And for the time period that they looked at and the cases that they looked at, the biggest group of people that used that were solving the cases were house staff at 60%, 21% were attendings, and 20% were medical students. And they're trying to answer this question of, do people, as opposed to the study that I am working on, that I have done, instead of looking at like working contemporaneously as a group in an interactive fashion, this is looking at collective intelligence, where people are making their own decisions in silos, but then seeing if we take multiple people's own decisions, can we improve accuracy? And so they did some pretty sophisticated statistical techniques in order to answer this question with using this data set. And they took, for each of those 1,500 cases in humandx.org, they took a random sample of 10 respondents for each case. This is actually a really nice platform to study this, because there is, unlike real clinical medicine, there is clearly a correct answer because the author puts in a correct answer. And so you can sort of definitively say, yeah, this is accurate or not. And they looked at two things: that the individual diagnostic accuracy by selecting one of the 10 different people's attempts for each case. And then they looked, this is the sophisticated statistics part, is they ended up trying to making varying size groups. So for the rest of those 10 people in the group, they made different collections using random selection of 2 people, 3 people, 4 people, 5 people, up to 9 people, and looked at, for those individual group sizes, what was the proportion of accurate solutions for the cases that were in question. And this is a graph showing the individual versus group accuracy overall. And the dotted line that goes across around 63% is the mean individual accuracy. So for a random person, this is how accurate they were at cases. And then you can see with the kind of uptrending line that if you increase the number of people that you're looking at, and sort of they did some proportional weighting to try to see what their answers were, they ended up seeing an increase over the mean individual accuracy starting after groups of 2, and then it continues to increase as you get up to 9. And I as a subspecialist, this makes me a little nervous, but this is in this part of the subpart of the study, the researchers looked at, if we took individuals that were non-specialists, so generalists, and looked at how they performed on a specialist case and compared that to an individual specialist doing the same case, where do they sort of line up in terms of accuracy? And as you can see, again, at the one individual generalist was not better than the individual specialist accuracy, and this represented by the dashed line. However, once you got up to groups of 2 or more of the individual generalists combining through that collective intelligence approach, they actually outperformed an individual specialist. So really interesting stuff that I think has a lot of potential implications for the future. So running out of time, I wanted to just kind of sum things up. So I think the takeaways for me from this was a way of thinking about, how do we move forward in this world of sort of augmented intelligence, and how do we sort of think of alternative ways to do crowdsourcing to improve clinical decision making, and then my personal interest is, how different is this from true collaboration, and would true collaboration potentially be a better or a worse way to approach this? And so with that, I'll respect my time and leave it at that. So thank you.
Thank you, Caitlin. That was very interesting. If you guys have questions, please put them in the chat box, and we can either read them for you or unmute you so you can read them yourself, depending on your preference. Okay, David has a comment. Can you guys unmute him?
Can you guys hear me?
There you are, yep.
A very nice presentation. I just wanted to share one piece of information that's sort of hot off the presses from an interval analysis that we were working on as part of our clinical trial. So we do individual and group assessments of the diagnosis in our AVERT phase 2 clinical trial, where we're looking at the diagnosis of dizzy patients coming to the emergency department. And what I noticed in this first analysis is that the performance of our 2 neuro-otology specialists is greater than the total group performance that involves the 2 of them plus 3 other people from other disciplines. So a stroke neurologist, a neuroradiologist, and an emergency physician. So their performance in figuring out the case based on information only available at the ED index visit is borne out about 70 some odd percentage of the time, and about 10% lower when the others get to them and they decide as a group what they're going to render as the final diagnosis. So I'm not sure that this is necessarily a real world reality, what they showed about the groups being better than the specialists, but with real data, it does kind of depend.
Yeah, I think that makes a lot of sense as coming from the specialist perspective, is that there are sort of the hard cases that the specialists see, I think would not, this finding would not be robust to that. And so there's something probably particular about the cases that are showing up on the site. And agree that that's a really interesting finding. I think that makes more sort of, that's more sort of like face validity to me.
I think we have time for one more question. Is there one? Okay, if not, if you guys think of one later and we have time at the end, we can always circle back around. Thank you so much.
Thank you.
Okay, next on the docket, we have Alexa Miller. She is the founder and consultant in arts and clinical learning at Arts Practica, and she's going to be talking about approaching uncertainty, identifying key features of mastery across clinical and arts engagement.
Hi everybody. Can you hear me okay?
Yes, we can hear you.
Okay, hello. Let me start this. So can you see my screen okay?
Yep.
Excellent. All right, wonderful. So I'm very glad to be part of this class of fellows who is the pioneering class of not all MD fellows. And so I'm very grateful to SIDM for supporting my research coming from a perspective in visual arts and art museum teaching. As a teaching artist, I've been working with medical learners around issues of diagnosis and diagnostic safety for almost 2 decades. And as part of that, have just been extremely curious about what differentiates masterful clinicians from the kind of standard fare workplace norm, especially when it comes to how they approach uncertainty and how they talk about uncertainty with patients and with one another. So in a nutshell, excuse me, my voice is not at its best today. So this has been my research question. And really sort of how is it, thinking about uncertainty as a fork in the road, a place where we have a choice to either move towards being part of some of the practices associated with poor quality, such as avoidance of uncertainty, failure to disclose it, labeling such as premature closure, search satisfaction errors associated with labeling, offensive practices and over-testing, or just downright apathy, versus having the courage and the confidence as a knowledgeable person who has invested a lot in their knowledge to not know and to stay calm in that space, maintain a curiosity, to think aloud and disclose uncertainty tactfully, to really work together with the patient, the patient's family and colleagues to co-create meaning, and to stick with it, to demonstrate a commitment, really honoring the relationship over the transaction of the diagnosis and saying things like, I don't know right now, but we're going to do X, Y, and Z, and I'm going to stay with you, and we are going to figure it out. There's a lot of really interesting scholarship and voices around this topic, but I kind of pulled this rubric from Paul Hahn's organizing taxonomy of uncertainty. So really, how is it that whereas one clinician might stand at the edge of their knowledge and sort of face a cliff, another might be able to put a foot forward and somehow finding a way forward in uncertainty? So that has been my question. And I've been looking at great diagnosticians sort of as a microcosm of people who do that really, really well. And why is that? Well, diagnosis, you know, we can think about diagnosis in one of two ways. First of all, as like the identification of disease, or the answer, or the name of the, you know, the problem, what is ailing somebody, or the process of getting there, sort of verbs of that knowing, the art of that knowing, as the and in that is baked a lot of wisdom. So as the musician Miles Kimpton says, the difference between knowledge is knowing that a tomato is a fruit, and wisdom is knowing not to put that in a fruit salad. So there's this aspect of diagnosis that really has to do with the art of knowing, and part of that is in approaching uncertainty very differently. So I've been exploring this in teaching. I'm going to sort of skip over my project, but if you the name of my course is called Looking with Uncertainty, and it is about how confident diagnosticians co-create a way forward. And I recently spoke about that, and you can go to my website, artspractica.com, to learn more. But I want to talk about the paper that that stood out to me over this past year as the most compelling and relevant to my research, which was this review that came out by Justin Lee in Harvard Review of Psychiatry on the idea of wisdom. So this paper was a massive overview of literature that looked at the definitions, the measurements, sort of the evolutionary basis of wisdom, and sort of how we see changes over time. And they looked at a range of things, from psychological studies to ancient texts, as a way to identify wisdom as a complex social trait that is in and of itself a construct that we can research, much in the way that resilience has recently become a construct that is now being researched. So this is sort of a way to propose a research agenda for looking at wisdom and thinking about the importance of wisdom in medicine and in medical education specifically, which personally I think is extraordinarily important, and I'm sure many people do as well. And it is something that is one of the things that stood out to me the most is that wisdom, it kind of is similar to the two-pronged definition of diagnosis about knowledge, is that it's different from knowledge in that you know, knowledge benefits the person, but wisdom is something that actually promotes the fitness of the entire species. It is something that is passed from the experiences of the elders to the young, and it is part of how we evolve. In fact, the term Homo sapien means wise human. It is literally sort of baked into how we make our way as a community. So these are some of the traits of wisdom that the authors highlight. There's social decision-making, emotional regulation, pro-social behaviors, self-reflection, acceptance of uncertainty, decisiveness, and spirituality. These are things that, again, sort of are not necessarily knowledge per se, but radically influence how we manage our knowledge, which in the context of health, and especially as technology more and more shapes how and what we know, is really important. So, and they suggest some links between wisdom and overall health of the individual, well-being, happiness, life satisfaction, and resilience. So I wanted to highlight two places that I saw this as really significant to the work of diagnostic excellence. So the first has to do with health itself. And the aspect of health, there's sort of this overlap between our knowledge and our health with wisdom being in the intersection. And this is really important for both patients and for caregivers alike. So how can caregivers facilitate the wisdom and the knowledge of their patients as they join with them to be sort of guides and partners in the co-creation of health? And also, as we look at burnout rates and issues impacting burnout and health of our workforce of caregivers, there's an aspect of wisdom that's extremely important there as well. And second has to do with knowledge itself and how we co-create knowledge in the age that we are in now, and especially I think apropos of what Caitlin just talked about in our collective wisdom. How can the wisdom at stake in looking for oneself at what is and finding a way forward. So some of you may be familiar with this graphic that outlines the difference between data, information, knowledge, and wisdom at the top. So we're surrounded by data everywhere. It's extremely overwhelming. And it's really up to us to take that data, to turn it into the right information, and then convert that into knowledge, and then that into wisdom. And what is it that drives that change, that conversion? It is interaction between people and with the knowledge and the material itself, which really speaks to this phrase, the whole is greater than the sum of its parts. That is because of the interaction in the spaces. There's a whole school of thought around what that means for diagnosis and social cognition, but wisdom is very much relevant to that as well. And then finally, acceptance of uncertainty. Where in uncertainty, find the way forward. Those are places that are very different from the norms and practices in most healthcare systems. So I want to be respectful of my time. But that is, I think that's in a nutshell what I'll say, and I'm happy to answer any questions now or
something that you need me for.
No, we're just gonna
Okay. All right. Thanks.
Great, thank you, Alexa. Does anyone have any questions for her? I have a quick question, Alexa. This is Ashley. So you talked about the difference between people who kind of go more on the fear side versus people who kind of go more on the learning side when approaching uncertainty.
Mm-hmm.
How do you think that relates to gathering wisdom? Do you think the learning side pretty much overlaps with that, or maybe one leads to the other? How do you see that kind of
That's a really good. Yeah, I see that as a choice that in the learning side of choosing to elicit new perspectives or inhabit the perspectives of others, including those very different from you, treating differences in knowledge not necessarily as a hierarchy, although certainly like having a situational awareness of who is the expert in any given situation is really important. But kind of a little bit different from traditional thinking about the idea, like the hierarchies that are based on knowledge and thinking about these differences as points of distinction. So yeah, it's really about that is one choice in uncertainty, is to pause and look at something in another way. You know, as much as many of the experts in the world of diagnostic safety may disagree with each other on a lot of different things, one of the things that kind of rings true across domains is this, you know, is the idea of a forcing strategy and taking a pause and looking at something in a different way. And that by nature often includes, you know, another perspective, the integration of another perspective.
Okay, great. That's really interesting. John Ely also has a question.
Hey, John.
Hi,
And
Alexa.
Oh, there you
go. I was interested in that pyramid where data was at the bottom and then came information and then knowledge. Yeah, that one. And I'm not sure I could distinguish those four apart. I mean, obviously, data is different from wisdom, but I wondered if you could give an example of each. That would be data that's not information or knowledge or wisdom, information that's not data, knowledge or wisdom, knowledge that's not information, data or wisdom, and that sort of thing.
That is such a great question. I think, and I would look at that in terms of like really sort of basic observations being data, and then observations with, you know, certain kinds of significance where you choose, I'm going to look at this one and not that one, coming into the realm of observation, and then how we synthesize all of that and begin to put it together as, I think of knowledge as a picture that's kind of always coming into focus and expanding. I'm a very visual person, but I think that that's the, you know, that's been a very helpful metaphor for me. But I think of that knowledge as the picture, and then as wisdom as sort of the pearls pulled from that picture that give you the principles of what one knows through years of interacting with that knowledge. I don't feel like I'm satisfactorily answering your question, and I would like to be more specific, but I don't want to take up much more time, and I don't have it like exactly available to me right now. So I would be happy to like get back to you, but that's a really great question. Thank you.
Okay, thank you.
Thank you, Alexa. Okay, next we have Vanita Prakash. She is an associate professor of pathology at the Yale School of Medicine. And today she's going to talk to us about a taxonomy of errors in pathology.
Hi, everyone. So I'm going to take a couple of slides to go over what my project was this year and then discuss the paper on serious harm and malpractice claim. Is everyone able to see my screen? Can everyone see my screen and hear me?
Yes. Oh, no, I don't see this. No,
I can hear you, but I don't see it. Oh,
there's your screen.
Okay. So going over my project, I can't advance my screen. Sorry, everyone. Okay, pathology is primarily a diagnostic field, so virtually all errors in pathology end up causing some sort of a diagnostic error, whether it's because of accuracy, timeliness, or communication issues. In spite of this, there's no standard classification of errors in pathology, and yet we actually have a formal system for collecting errors that is used at virtually every hospital. Nope, sorry about that. Because accreditation requirements require us to reconcile diagnosis when an error is discovered. And so we issue amended reports for that scenario. And every institution, for most part, monitors these amended reports, and these can serve as a surrogate for error. I'm sorry. So our aim was to review, come up with a system for reviewing amended reports to classify errors and then create a cause-based taxonomy of errors so that we could then eventually implement corrective measures to reduce diagnostic error. So we set up a database, and our IT team, especially Dr. Senard, Neil Mutnick, and Peter Gershkovich, played a very important role in setting up the database. And this is what it looks like. So this is a diagnostic report that was issued, and there was an error in here which has been corrected. So Part 11 and Part 12 were labeled exactly the same as right lateral mid and with benign prostatic tissue, and the diagnosis of prostatic adenocarcinoma followed the benign diagnosis. This case was brought to attention as having something that was incomprehensible by the clinician, and so the pathologist corrected the report. So what they took out of the report is in red and it's crossed out, and the new terminology is inserted in blue, so it allows us to see exactly what was changed. And then what the clinician or the pathologist has to do is that we have a taxonomy that we've created, basically which monitors issues of accuracy, issues of communication, issues of timeliness, and a fourth category which we've created, which is administrative errors. And the pathologist has to select a label for the error, enter how and who discovered the error, and determine whether there was clinical significance to it, and put in a descriptor of how the error occurred and whether the corrected report was communicated with the clinician. So the original goal was to review 1,000 cases, which we have collected, but I did an interim review, and clearly we need to do some work here. So we did a review of 416 cases, and the pie chart shows how the cases fell out. The majority of these were communication errors. There were about approximately 20% interpretation errors, and then there were 28% administrative errors. The administrative errors are in some ways the easiest to address. So for instance, one of the administrative errors was that we were having patient cases being logged to the incorrect patient. So we're actually working with Epic to create a process by which that information and specimen labels will directly transmit into the lab information system so that the specimen doesn't get labeled. In anatomic pathology, a mislabeling can cause serious issues. So you can imagine, it's not infrequent for a patient to have biopsies, breast biopsies on both the left and the right breast. And if those two get switched, we do have errors that happen from things like that. So we have been able to put in measures to bring down the administrative errors. Interestingly, our communication errors seem to be tracking upwards. This is compared to previous year's data, but the collection was in a different system, and I'm not entirely sure why that is, so we're going to be studying these more. But one of the other issues that we found was that there was significant classification variability and also the information that was being provided by the users. So as an interim measure, what we did is that we presented these results to our faculty, and we're trying to further refine and standardize the interpretation of the terminology that we're using, because people are interpreting that differently. And so that's where the project stands. So I chose this paper, and I think 3 of the people are in this discussion session, so I don't know. So please jump in if you think that I'm misrepresenting portions of the paper. So the goal of the paper was to estimate the US burden of serious misdiagnosis-related harms by looking at malpractice data from 2006 to 15. It was a very large set of cases that was drawn from the CRICO CBS system, and it was a code-based review that was done. Looking at these cases, what they found was that 21% of the cases were diagnostic errors, surgical 28%, medical 23%. The big three, which is cardiovascular, sepsis, and cancer, accounted for approximately 60% of all diagnostic error cases, all severities, and 70% of the payout. Among the high severity cases, by high severity, we mean death, either severe or permanent disability. The big three accounted for approximately 75% of the cases. Looking at the cases closer, there was an average of 3.7 failures per case, and clinical judgment factors were identified in 85% of the cases, and of the clinical judgment factors, the top 5 were failure or delay in ordering a diagnostic test, a narrow diagnostic focus, the failure to appreciate and reconcile relevant symptom signs or tests, failure or delay in obtaining consultation or referral, and misinterpretation of diagnostic studies. In addition to that, there was sort of disease-specific and site-specific workflow patterns. So as you can imagine, vascular and sepsis cases were primarily happened in hospital settings, whereas cancer was primarily in an ambulatory setting. The cancer misdiagnoses had a higher percentage of missed results. It was close to 17%, whereas this was not true for the vascular and sepsis cases, probably because of 2 reasons. One has to do with the setting proper, and the second has to do with how cancer is diagnosed and followed. These are primarily ambulatory cases, and patients shift between clinicians a lot more. For the same reason, cancer misdiagnoses was not impacted by weekend issues, and cancer diagnosis resulted more commonly in disability, while vascular misdiagnosis failures were more likely to result in death. So the limitations of the study, one of the reasons that I was attracted to this paper is that I have some reservations about using malpractice-based data to study misdiagnoses, in part because it influences our practice behaviors. And so if you look at all of these cases, there were supplementary tables listed. We have a lot of cases that look like, and I can't be sure, but they look like missed cancer diagnoses. There's a very small number of benign cases. And so I think this sort of drives sort of physician behavior patterns, in that it promotes a certain amount of over-testing. I don't think that, the paper shows that, but that's one of the issues that I was hoping to get some insight on, and maybe the authors of the paper can comment on that. The other question that I had, which perhaps connects to Kelly's work, is that I'm a little uncomfortable that the patient perspective is not adequately reflected in this paper. I would also have liked to know the distribution of sort of jury settlements versus sort of out of trial settlements, because jury trials are falling in the country, and they also tend to be very much of outlier compensation cases. So I'm not sure how this affects the data, but it's a very detailed and interesting paper. I think folks should read it. And I don't know, do the authors have any comments?
This is David. Can you hear me?
Yeah.
Yeah, thanks. So I think you did a great job, articulating some of the issues. I guess I can't speak directly to the issues about jury trials and non-jury trials, and Dana would have to help us with those. I don't know if she's on the call as one of the unnamed callers or not, but in terms of the issue of, the main issue in discussing the whole representativeness problem, which is kind of the critical problem when people talk about malpractice data, is it representative of clinical practice? And at least as far as we can tell, based upon the work that we've done subsequent to this paper and will be coming out in the next few months, the malpractice data are non-representative in a very specific set of ways. Mm-hmm. So the malpractice data are non-representative for sure in terms of overrepresenting false negatives as opposed to false positives.
Right.
Which you articulated. They overrepresent serious harms relative to minor harms, for sure. And they disproportionately overrepresent cancer cases relative to vascular events and infections, presumably because there's much more of a paper trail that can be used as legal evidence to win a case. Whereas the others that unfold much more quickly boil down to he said, she said judgments about whether the diagnosis could, would, or should have been made. If there's a radiograph that shows a nodule and they show that to the jury and say, here's the nodule, it was there, nobody followed up the image, that's a slam dunk case by comparison. Those three areas appear to be the main ways in which malpractice data are non-representative or biased, if you will. Mm-hmm. But probably in terms of some of the key features, like roughly the distribution of diseases within the vascular bucket, or the distribution of diseases within the infection bucket, or the distribution of diseases within the cancer bucket, those appear to be probably pretty close in terms of rank order to what we're seeing out of the population level numbers, with some minor exceptions where certain very high disability type conditions like spinal abscess and meningitis, where people get horrible, horrible outcomes, are sort of overrepresented relative to their population level numbers. So I think what we'll see as we release the next two iterations of the paper, one's under review and the third one will be coming out shortly after that, is understanding better the ways in which malpractice data are biased, rather than just saying malpractice data are biased and then dismissing them on those grounds.
Thank you.
Yes, thank you. That is a really interesting perspective. We're lucky to have both the authors and a presenter in the room at the same time. In the interest of time, we're going to go ahead and move on to the fourth speaker, Dr. Kelly Gleason. She is an assistant professor at Johns Hopkins University School of Nursing, and she will talk about leveraging the patient experience to improve diagnosis and about her fellowship experience. I see your slides, they're very zoomed in. Maybe that's just me. I don't hear you though. Does Kelly need to be unmuted? I can't hear her.
Hear me? Okay.
Yes, now we can hear you.
So now you can hear me. Okay. zoomed in, but after the slide, it shouldn't feel as zoomed in. So I'm going to be talking about leveraging the patient experience to improve diagnosis. And I'm going to be going over this very broadly just because in the interest of time. So my mentors for my fellowship were Dan and Welcome Jarday, who, if you're familiar with them, they are patient advocates themselves. And they really did an excellent job at constantly pushing me to make sure that the patient's perspective was at the forefront of my project and I wasn't just thinking about it from a nurse researcher perspective. And I'm just sharing this image here. It was in the Patient Safety Pennsylvania State Authority's first issue, because it really shows that even though we think that sometimes we understand the experience of the patient because we've been a patient before, there's nothing like, we really can't. We can't know what it's like to walk into a hospital and have no idea about all the different roles and all the different pieces. So for my fellowship, I developed and pilot tested a patient-centered measure of diagnostic error, which I called LEAP, leveraging patients' experience to improve diagnosis. The results have been very interesting, but that's for another time. So the presentation, the article that I chose for today's presentation, and similar to Vanita, I know that there's a couple of the co-authors on the call, and it's Learning from Tragedy, the Julia Berg Story. And I thought that this was so important because Dan and Welcome were not just listed there as co-authors to check the box that patients were included in the article, which I think sometimes happens. I think that you have a patient, review it in the final stage and call the patient the co-author to click that box. And this was different. Dan and Welcome had a section of this case study that was dedicated to understanding the scenario from their point of view, their experience. And so the way that it's structured, and I really commend the authors for this, is that first they give the case and that typical heavy clinical details. Then they present it from Dan and Welcome's point of view, written from their perspective, and then it presents it from the hospital's point of view and ties it all together. And the one thing that I'll say is that this is a huge step forward, and I would go one step that the nurse is mentioned a couple different times in this case scenario, and the nurse and what they did seems to have a role in they possibly could have been a part of catching it earlier, had different things done right. And so I would say that the one voice I thought was missing was possibly the nurse, because Welcome actually directly calls out the nurse, that she said that, Welcome noted a few different times that she was worried about what the monitors were showing. And the nurse kind of poo-pooed the concern and was really focused on cleaning up because the daughter was having a GI bleed, so it was on the bed and such. And I think hearing from the nurse's perspective about, how possibly they felt after ignoring these concerns and then seeing it develop into a code situation when it possibly could have been identified earlier. But again, I just have some observations teased out here that are just from Dan and Welcome's section. And you can see that they wouldn't be included in a typical case study because they're very personal. They're very much so things that, the parent, the family member in the room would notice. This offhand comment from the doctor early on in the situation. Wow, I thought that she might have leukemia based on her presentation. These are things that you remember if you're the patient, you're the caregiver, but they're not things that are documented. They're not strict pieces of data. And really the best way to get them is by directly talking to the patient. So to conclude, I think we have so much to learn from flipping traditional role dynamics. And I think it's being more and more encouraged in current funding mechanisms, everything, to make sure you have a patient on the team, but to really be really meaningful about how you're including that patient on the team. Don't just check the box and have the patient, in the room and allowed to comment here and there, but not really feel like they're a strong voice. Make sure that they feel fully empowered and give them the full section of the paper. The fact that Dan and Welcome mentored me, which is in typical role dynamics, the mentor hires the mentee. I have to be responsive to what they say. That's a lot different than just being on a call with a lot of intimidating researchers. and feeling, maybe some difficulty speaking up. I think that in my mind, I think that SIDM does better than most other organizations I've ever seen at including the patients as equals, but that we have to continue what we're doing and continue these efforts and include even more patients just so that we're getting fresh perspectives in there. And again, in the interest of time, I'll stop there, but thank you so much for listening.
Thank you, Kelly. That was really interesting. I actually have a question for you while we wait to see if other questions come in. How did you, as a team, go about including the patient in this particular, or the patient's family article? Did they approach you, or can you just talk about kind of the process of involving them in this? Or no, you
Mark
on this project.
Yeah,
Mark,
I was going to say, actually, Mark
meant.
or Benita might know.
Yeah, it'd be really interesting to hear from them on how they actually went about, that's what I meant to say, I'm sorry, involving Dan Berg and how that went.
Yeah, and while Mark and Benita are getting unmuted, I know that Andrew Olson, who was a part of the paper, but I believe isn't able to be on today, was saying that it was really interesting going through the editing process because there were things that needed to be cut out. But when you're sharing a story that's so personal and powerful to you, it was just an interesting experience going through the editing and taking out certain parts that to them were very valuable. But Mark and Benita, if you guys had any comments about how you guys started the original idea of the paper, would be excellent.
Mark did add a comment. I don't think he has a mic. He said he worries that this kind of article will be engaging for patients, but that it might be a turnoff for docs. Do you have any response to that?
I think that's a really interesting thing because I have to say that I get this feedback a lot, with being patient-reported diagnostic error, that when people first hear about it, some physicians, oh, that makes sense. But some physicians are like, oh, but patients don't know their own history and patients aren't reliable. And I think that when you actually see the resulting and you think about it and you think about all these little pieces of information that you wouldn't have unless you directly followed up with the patient, the value becomes without question. Like it's really difficult for me to see why you wouldn't want to see all these little details that from the patient's perspective you miss. Like when I read through Dan Welcome's section, again, these different things, like the fact that Welcome was pointing at her chest when before the pain was in the abdomen, the fact that it possibly could have been a rapid response, so the rapid response came afterwards if identified sooner. It's just, it's really hard for me to understand why that perspective wouldn't be valuable. And then Benita lost audio for a bit. She found them really Benita found them really wonderful to interact with, and as pathologists, hi Mark.
Hi.
Yeah.
So the Bergs were very involved in this case at the medical center level. There was some sort of agreement or negotiation with the people at the center where this happened, and the medical center set up an annual conference where errors like this would be discussed, and the Bergs are very involved in that. I spoke at one of those meetings. So, they've just been tremendous in terms of being very effective patient advocates. Dan was at our recent DEM meeting as an example.
Yeah, they're fantastic. But I think that we're currently trying to get other patients feeling very comfortable being a part of dissemination at Hopkins. And I think it's just constantly reminding them that their perspective brings so much to the table, that they are welcome, that they are included. And I know that the patient partners that we brought to the Diagnostic Error in Medicine conference were thrilled to be there, thrilled at what excellent people the SIDM group is, everything. So.
Yeah, that's great. Thank you for sharing your experience, Mark. And speaking of Mark, since you're still on the line, I think, did you want to ask the question you had earlier for Caitlin? We have a couple minutes, or I could read it as well.
I saw the question. I think what the question was what is the clinical application of the collective intelligence paper? Is that that we're thinking about?
Yes, that's it.
Yeah, I think that's so fascinating. I obviously could go like a bunch of different ways, but I'm trying to think of like how would if I could look into the future and see where would this get applied. You know, you can imagine a scenario in which based on what prior physicians have done or prior clinicians have done at a stage when you're sort of like reviewing data or when a piece of information comes up, you know, the medical record could know that, hey, every time this lab test is abnormal, the, you know, 85% of clinicians then go on to look at this other test or then go on to order this thing, or you know, whether that be additional diagnostics or treatment. So I could imagine a future in which sort of similar patient data scenarios are then sort of translated and people are given, you know, it's built into clinical decision-making pathways, so people can sort of see what their peers have done. I think there's a lot of anxiety towards something like that. Like obviously we're okay with that for choosing our next Netflix movie, but a lot of physicians are really uncomfortable, clinicians are really uncomfortable with that idea, and I think patients might be uncomfortable with that idea of sort of being treated as an algorithm. There's some, I've heard people talk about ways to make it sort of more acceptable, like perhaps that it's only clinicians from your system or, you know, your sort of like peer group, rather than sort of like this is what the computer says to do, but instead to emphasize sort of the previous actual people have seen this information and then moved on to, you know, look at this other piece of information. Maybe a way we could think about data visualization or organization of the chart, or maybe it's even more, and it's thinking about like maybe just using it as a stop, so that you know, something similar like we have that that's based on a different principle, but that you know, it doesn't let the record doesn't let you order a C. diff toxin within a week of it being positive, because we know it will be positive again. So you have to then sort of justify why you would need it again. So to sort of build it into sort of clinical decision-making pathways, either to proactively get people to do things or show people information in a different way, or to stop them from doing things we know are of low diagnostic value.
Thanks, Caitlin. Really interesting.
Yeah.
Yes, and thank you all. I think we are out of time. Thank you for the encore performance and for sharing a snippet of your research and some very interesting and diverse articles that I think some of us may not have encountered elsewise. Is that a word? Anyway, good luck with your ongoing work. And again, thank you so much. And thank you everybody for attending. If you have recommendations on future journal clubs, please reach out to us.